So welcome to this next session. My name is Renee Pellegrin, and as if you've been at the previous section, you know that I am a journalist, and I can declare that I have no conflict of interest. I'm not being paid by any pharmaceutical industry or any charity organization or anything like that. But some people who are advocates of screening have perceived that just because I've written a book, I have a conflict of interest. But I don't believe that I do. I would like to introduce, we're going to have 3 guests talking about messaging on breast cancer. And the first is Cécile Bourg, who is a radiologist, president of Cancer Rose, an organization fighting for the objective information for women on breast screening. Cécile, could you come up, please?
Hello to everyone. So my name is Cécile Bourg, and I am a radiologist, and I will present you today from balanced information request to censorship the situation in France. I am the president of Cancer Rose. It is a French non-profit organization, and Cancer Rose has the mission to provide independent information on breast cancer screening based on scientific literature and based on what we are learning here during conferences and congresses. I declare no conflict of interests. So at the beginning of the French story, in 2015, the French Ministry of Health organized a citizens' inquiry, a scientific and citizen inquiry on breast cancer screening. The steering committee at the end of this inquiry recommended balanced and comprehensive information for women with taking into consideration the scientific controversy. 2 scenarios were proposed. In both, the word stopping screening appears. The French National Cancer Institute, so-called INCa, was entrusted with implementing the action plan despite the critics received by this institute during the inquiry. Then, only after 2 years, in 2017, INCa published a very insufficient information booklet sent to 50-year-old women invited for their first screening. Benefits are overstated and harms minimized. Percentages are used instead of absolute numbers, what the citizens asked for. Then in June 2021, the INCa issued a new leaflet for women invited for their subsequent screenings. Although the former booklet minimized overdiagnosis, at least it mentioned it. But now there is no mention of overdiagnosis or radiation-induced cancers, and false positives are unclearly presented. On the first page, we can read that screening saves lives. Next, the claim that 99 out of 100 women will be alive 5 years after diagnosis, but we know it that does not guarantee the effectiveness of screening. And on the last page, you have INCa's new slogan, which is emphasized by using bigger letters. Early breast cancer detected, better the chances of cure. Of course, but the real question is and remains, is screening able to detect the most dangerous cancers and early enough? In September 2020, INCa organized a new citizen consultation and proposed measures for the next decennial cancer plan. 2 of the proposed measures drew our attention. One measure is related to financial incentives for women to increase screening uptake and reach the European objective of 70% of uptake, of participation. And the second measure is to combat fake news on cancer and censor the independent information on health. And I propose now to focus on this measure. INCa decided in the new cancer plan to set up a reactive system to combat fake news and to investigate the creation of a CSA of Health Agency to establish rules in the field of health information. What is CSA? It is the acronym of Conseil supérieur de l'audiovisuel. It is the French regulator of audiovisual, the French watchdog for audiovisual communication. The reservations expressed by some citizens did not stop INCA from adopting this measure with great diligence. The decision was based on only 124 voters. If this isn't censorship, it sure appears to be. As you can read here, this CSA of Health Agency will implement rules for information on health, and indeed, a college of experts will be appointed to identify the fake news and eliminate them. So you can read rules provided in a framework agreement with content hosts, so that requires that content host can remove what INCA has qualified as fake news. But who could believe this promise of independent experts when INCA has been conflating and confusing screening information with screening promotion, and this for years? In parallel, in 2021, INCA launched a web page with the title Enlightenment: Information Behind Fake News. And on this web page, INCA qualifies as fake news the international controversy on breast cancer screening. So here you have some screenshots from this web page where we can read, for example, no, breast cancer screening is neither useless nor causing harms. Its benefits are undeniable for women. Or to remember, breast cancer screening brings women a far greater benefit than risks. Here INCA asks, why is it a fake news? And the response, as a scientific study shows, the reference is INCA itself, the benefits of breast cancer screening far outweigh the risks. This scientific debate may negatively impact women and turn them away from the screening, and medias are accused to relay this controversy. Here it is linked to the overdiagnosis, so we can read in 10% to 20% of cases, the lowest assessment given of overdiagnosis, some tumors will not progress. Therefore, they may be subject to what is called overdiagnosis and to treatment that they could do without. But they are real cancers. So you see, this last sentence is highly misleading, as these overdiagnosed cancers, by definition, are totally harmless. And of course, there is no mention about overtreatment. Here, on this page, the question is posed. It is asked, why is this fake news dangerous? And the answer, because 12,000 women die from it, and mammograms detect small cancers. But once more time, the real question is screening able to detect the most advanced and deadly cancer, and this early enough for the woman? So clearly, the INCA has chosen to consider overdiagnosis and overtreatment as the price to be paid to avoid breast cancer death. This could be a logical choice, but women informed could have another choice. As you can see, as scientific evidence quoted by INCA, we can find INCA itself, 4 references on 6, and the 2 other refer to Institute for Radiation Protection. And there's another occurrence about mortality reduction given in percentages, 21% instead of absolute numbers. So we have 3 major concerns. One is that the French INCA may gain excessive power in the future, forcing internet media and social networks to censor information and eliminate information. The second is that the ethical principle of non-maleficence is blatantly disregarded. INCA affirms screening as having undeniable benefits for women, but INCA also admits that a small percentage of women will be overdiagnosed and treated unnecessarily, even in the case of a massive overall benefit, which is not the truth. Some women will benefit at the expense of others. Such a justification violates the fundamental principle in medicine, first not harm, and it is really first not harm. The third question is on the legitimacy of the INCA to provide information and take a right to designate fake news. INCA was criticized already for poor information quality in the Citizen Inquiry report. It was also pointed out in 2 academic studies. In the first study carried out by French authors, the information provided by INCA is compared to the information provided by our association, by Cancer Rose. Results show that Cancer Rose scores significantly better than INCA for all criteria. The second study is carried out by Danish authors. This study denounces methods for influencing the public to increase screening participation. INCA is mentioned in 2 systematic categories: misleading presentation of statistics and misrepresentation of harms versus benefits. So we can ask the question, is it legitimate for this institute to censor and eliminate fake news? INCA's strategy is similar to the use of the carrot and the stick. It refers to a proverb, a phrase in French, la carotte et le bâton. It refers to a donkey that has difficulties for moving forward without motivation. If you show him a carrot as a sign of reward, or if you hit him with a stick, he will move forward in both cases. Regarding screening, INCA threatens censorship with CSA or accusations of fake news, while also promising reward, financial incentives. Recent publishing in the BMJ addresses financial incentives used for screening more women. Among the authors, you can find a French citizen woman. So the conflict of interest of the INCA assigned by the legislator, assigned 2 contradictory missions, makes it absolutely necessary to have other sources of information that are independent of INCA. So in conclusion, there are 3 possible explanations for INCA motivations. Perhaps first, the resistance to screening. The greater the public's resistance is to screening, the stronger health authorities' response by whatever means necessary. Secondly, a strategy of letting the situation rot or letting the controversy end is used. And third, the poor reactions from the media busy with covering the pandemic situation. Indeed, only some media mentioned the topic of the censorship and women's misinformation in screening. So this new INCA step is a shock to everyone believing in the scientific and ethical method. Refusing to debate and reducing any form of disagreement to the level of fake news is unworthy of scientists. In France, we don't know what the future will bring, but we are quite concerned that the red line crossed by INCA for many years has been entirely left behind today. Thank you for your listening.
Thank you, Dr. Boer, for that excellent presentation. And I think it highlights how important messaging is as a driver of overdiagnosis. If the message is, get screened, it's going to save your life, and that is the only message getting out there, then obviously we're going to encounter cancers that don't need to be treated. our next guest, can we have Dr. Mehta? There she is. My pleasure to introduce Dr. Mehta Gallagher, who is a professor of medicine at the Medical Facility University of Oslo and Oslo University Hospital. And that we're so happy that she's going to be here with us today.
So good morning or good evening, depending on where you are. I'm sorry my voice is a little bit bad, but at least it's better now than it was a couple of days ago. So I will talk today about what women knows about mammography screening and why do we promote screening, and does neutral information matter? What is informed choice, and how do we fix the mess that I will describe? And then finally, I'll ask a very provocative question: does informed choice work? So my conflict of interest is I would say none, but I'm a researcher in cancer screening, among other things, and clinical effectiveness. But I wouldn't say that gives me, or that you could classify me as having a conflict of interest. So what do women know about mammography screening? And you may be aware of this study published in the New England Journal in 2014. It's about women's perception of the effect of mammography. And it's about the real effect of mammography. So when you look at these 4 boxes, there's one with screening and one without screening for the perception that women have. The A figure and the B figure is the real effect of mammography. And what do we see? Well, we see that the women alive, the blue boxes, are about the same size in both perspective, although much, and then we see that the orange boxes, which represent women who die from breast cancer, and the yellow boxes, women who die from other causes, are very different in the way women perceive the effect of mammography screening versus the real effect of mammography screening. And as you can see, that they overestimate the risk of dying from breast cancer. Not only the risk of dying compared to other causes that we can die of, but also the risk compared to how many women who's actually alive. And this is a study that was done in 2014, and it may be a while ago, so this might have changed. But a recent study based on participants in a mammography screening program in Norway show that only 50% of all women have ever heard of overdiagnosis. And even worse so, only 14 or 15% correctly identified the definition of overdiagnosis. So it doesn't seem that women's perception of mammography screening has changed recently. So why do we promote, or why has mammography screening been promoted? Of course, because we believe it works. And this is one of the doctrines in medicine, I would say, that we really do believe that the best strategy to be healthy is early detection. And as many of us know, this might not always be a good strategy, so we need to work on that strategy. So does neutral information matter? So this is a study not done on mammography screening, but on colorectal cancer screening. And this is a study that has 2 parts. One is an interview study, and the other one is an online RCT, where they answered questions on a questionnaire. So what they did was the Think Aloud study, or the interview study. People were interviewed about whether they would undertake 3 different screening tests: sigmoidoscopy, colonoscopy, and fecal immunochemical testing, so-called FIT. And they were presented with a 15-year risk of cancer varying from 1%, 3%, and 5%. And they were all asked if they wanted to attend or not attend screening in the 3 different scenarios, or the 3 different risk levels of cancer. And what they found in the study was that the intent to screen was not associated with information on numbers of benefits and harms. but rather decision was based on prior beliefs. And one quoted that as long as 1% benefit, it is worth it because it could be me. So from the online RCT, you will see that it doesn't matter what the risk level is. So the balance of the benefits and harms doesn't really matter. Approximately 2/3 of all the participants wanted to participate in screening no matter what the risk level was. So, and then we move on to, we always say that we need to make women or people informed so they can take an informed choice. And what is an informed choice? So this is a study, a randomized study from Italy, where they compared decision aid and with the standard procedure brochure that was given along with the invitation to mammography screening. And what they found was that more women reached informed choice with a decision aid, but there was no difference in attendance whether the women had informed choice or not. Whether this is due to the fact that women don't understand the numbers, or whether this is due to the fact that the data that they presented in the study was based on data where the benefits and harms, or where they provided the most beneficial benefit harms ratio. So the number of saved, which is here on the graph, the women, the red bars, it was presented as 8 women is saved versus 4 women overdiagnosed per 1,000 women screened. And when you compare these numbers to the Cochrane review, where the Cochrane review said that was one woman saved over 10 diagnosed, whether it was the information that was given and whether this is really informed information, or whether this is a balanced information, I'm not sure whether it's the information or whether women don't really understand the numbers here. So how do we fix that? It doesn't seem that neutral information matters, and that it doesn't matter if you reach an informed choice or not, you will still participate in screening. And not to say that we should not participate in screening, but how do we fix both what is informed choice and how can we talk to women and individuals, and what kind of information should we give them? Well, first of all, and you probably agree with me, is that we should base our information on the data from randomized trials. And another way of doing it is that when we do give recommendations in guidelines, we could try to do it more tailored, based, for example, on risk. And this is what is done in this guideline for colorectal cancer, published in the BMJ in 2019. The evidence for recommending FIT, sigmoidoscopy or colonoscopy screening is weak. But here, the recommendation was based on the risk, your actual risk of cancer in the 15 years ahead of you. So they recommended no screening when the risk was below 3%, and they do recommended screening when the 15-year risk of cancer was above 3%. But this was based on the preferences and values of the guideline committee. And we don't really have good data to inform us what most people would actually think is the beneficial threshold to when to recommend screening. But this is at least one way of thinking when we should give recommendations in guidelines. We also have to remember that medicine is also a business, and we need to work and we need to be aware that early detection does not always work. We also have to remember that screening is usually systematic. It's either in screening programs or it is a push or a nudge, because in some countries like the US, you will have a higher health insurance, you will have higher health insurance premiums if you don't attend screening. And also, we have to remember that attendance is a quality indicator, and I think we should move away from that. And another important thing, when we do have systematic screening programs and a push to go through screening, is the popularity paradox that you might be aware of. The more you screen, the more you overdiagnose, the more people have the feeling that they're saved, and you have success stories that people can tell other people. So you increase the awareness of the disease, and also the benefit, you increases the thinking that benefit is, it's always benefits with screening. And this is important because people reason from anecdotes and not necessarily based on informed information, or they don't make an informed choice. So do we need to move from informed choice to try to again promote screening by telling patient stories on overdiagnosis? I don't know, but at least we have one study published a couple of days ago that really looked at the effects of awareness of breast cancer overdiagnosis among women with screen detector or incidental found breast cancer. So I will end my talk right now, and I hope we have a fruitful discussion on how we're going to promote screening. Should we do neutral messaging, or should we actually tell patient stories about overdiagnosis? Thank you so much.
Thank you very much, Dr. Gallagher. I just want to address your point about women understanding risk. In my experience, talking to women who women do not understand that only 3% of us will ever die of cancer, breast cancer. And you think about it the other way, 97% of us are going to die of something else. And that is something that women just absolutely do not hear. And I think that's something that we could work on. My next speaker is Dr. Clarenbach, who is a professor of medicine at the University of Alberta and vice chair of the Canadian Task Force on Preventive Health Care. Over to you.
Thanks to the organizers, and thanks for Renee for organizing this session and inviting me. It's an honor to be here. I do have disclosures, including my research funding. I'm also director of the Real World Evidence Unit, which is comprised of the University of Alberta, University of Calgary, and Institute of Health Economics, that has arm's length funding from both industries as well as decision makers, including the Canadian agencies in drugs and technologies and health, in order to inform more appropriate use of drugs and technologies. It's unrelated to this talk. So I hope I'm not telling you things that you haven't already heard, but I'll go through the basics just to begin with. First of all, as everyone knows, all screening causes harms. If we're inviting otherwise healthy people for screening, we better be very sure it behooves us to make sure that there's a net benefit. The Canadian Task Force on Preventive Health Care did a systematic review on the evidence of benefits and harms and found that with available evidence, there is a reduction in breast cancer mortality. However, the absolute benefit for younger women is very small, with a large number that require to be screened in order to prevent one death due to breast cancer. An opposite pattern is observed for harms, where younger women tend to have more frequent occurrence of false positives, and false positives including those that go on to require a biopsy. Similar trends are seen for overdiagnosis, where younger women tend to have a much higher proportion of cancers that are diagnosed that are deemed to be due to overdiagnosis. And this is from a long-term follow-up of a Canadian randomized control trial. So it's one thing for us in the working group to get this information, but what we're really interested in is how do women perceive this information and how does that influence the construction of our guidelines. Our Evidence Review Centre, that in conjunction with the Canadian Task Force, conducted a systematic review of values and preferences in order to answer some of these questions. And what did it show? Well, it did show that women put a very high weight on averting breast cancer mortality, and they're willing to accept substantial harms in order to achieve that benefit. When overdiagnosis was presented in an understandable way, this was one of the most significant harms, and in many situations did have an impact on their decision making. In general, from the systematic review, where there were scenarios where the absolute benefit was relatively low and the harms were significant, this did lead to a change in the perception of the benefit in screening. It reduced or reversed the perceived benefit, and many women in that younger age group would decline to be screened. In the older age groups, 50 and over, where the balance of benefits and harms is a little bit more favorable, most, but not all, were willing to accept the harms in order to achieve the benefit. And that kind of non-universal acceptance or non-acceptance of screening, I think, is an important consideration. This informed our guidelines. These are the guidelines in 2011, which used some of the old grade terminology, and we modified it so that we included a conditional clause, ensuring that it's conditional on the relative value that a woman places on possible benefits and harms. It's less black and white, it's less directive, except for the direction that there are a variety of values and preferences, and those should be incorporated prior to making the decision to embark on screening. Some of this has been presented earlier, but I'll go through it as it did come up in our systematic review. How you present the information to women making a decision about screening is critically important. Even though these were academic papers in the peer-reviewed literature, some of them did not adhere to the best practices of international patient aid standards. They may be presenting things like relative risk instead of absolute risk. They may present a very skewed example of overdiagnosis, or present overdiagnosis in a way that was challenging to understand. And similar to what we heard in the previous discussions, that even when there was a really comprehensive and thorough approach to convey exactly what overdiagnosis was, many participants were still confused by it and saw it as a consequence of treatment rather than a harm of screening. However, one thing to keep in mind is that this is a review of the literature of previously conducted studies. So there is a generalizability issue. Women who participate in studies, or anyone who participates in studies, tend to be a little bit more higher socioeconomic status and higher education. However, there was an overwhelming majority of women who participated in these studies who wanted to be involved in decision making, 80 to 96%, depending on what study you looked at. They wanted to know the harms, they wanted to know the benefits, and they wanted to be involved in making the decision if they should be screened or not. With our knowledge translation team and Sharon Strauss, we came up with our patient guidelines or information aids to help present this information in an understandable fashion. I won't go through this in detail, but it provides information by women at different age groups. We subsequently also developed a decision aid, which is done online as well as can be done in paper, to help walk women through each of the different elements of the risks and benefits, presented in a way that's understandable so they can make an informed decision. Now, all that sounds great, but it might not be enough. We all like to think of ourselves, or we like to think our patients should be informed and can make rational decisions. But other factors influence how we make decisions every day. I'm not a social scientist, but many of us use heuristics, which are psychological or mental shortcuts for making decisions. If you had to weigh the benefits and risks and uncertainties of future events for every action that you did, you'd be paralyzed by indecision. So we use these shortcuts, and one of those shortcuts is people do what they've done before. So again, from the systematic review of these values and preferences, it found that if people were screened before, they're more likely to continue with screening regardless of the information they were given. A second important factor is that human beings are social animals, and we respond and adhere to cues, norms, and the social milieu in which we inhabit. So one of the kind of more striking pieces of information from this is that the decision or attitudes and beliefs about being screened were far more likely to be dominated by attitudes of the circle of acquaintances, that's a quote, and less by information on screening. Furthermore, the ability to make informed decisions and use the risk-benefit approach was undermined in many circumstances by perceptions and beliefs that probably weren't true. So when there is a lot of emotion, anxiety, fear, the thought of cancer terrifies me, so I have to do everything I can, often that overshadowed information being presented to women. And a lot of this can be presented back to the role of media, social media, and campaigns, which I think, if to be fair, a decade or 2 decades ago, we didn't know nearly as much about overdiagnosis as we do now. And I think some of these campaigns were set up, at least initially, maybe I'm being generous, but they were set up initially by the thought that screening did improve outcomes. That might no longer be the case. What's happening in Canada? Well, we produce these guidelines and we pay attention to what happens and what comes out in the media. And we have seen some negative press regarding it. Here's a few examples. You can see from the headlines that they tend to advocate screening, especially for younger women. There's often a fair amount of fear and anxiety around it, mistrust of experts. The guidelines have it all wrong. Breast cancer survivor disagrees about screening for younger women. And there's also, not even just with respect to screening, but don't just get screened, but if you have other abnormalities, get additional supplementary screening. I think if many of you, the other sessions before, heard about breast density and how there's some advocates for doing additional screening. Additional screening, which we know has harms. There's increased risk of false positives. There's likely overdiagnosis, although that hasn't been determined yet. But there's no evidence on benefits from randomized controlled trials using clinically important outcomes. In addition to this being in the media, it's also being presented to physicians. So this is an example of a result from a breast cancer screening where it's saying that to the ordering physician, the patient has breast density and you should consider getting additional testing. It's notable that the negative press that has been received and these kind of messages that's been getting out has largely in Canada been due to a small group of radiologists. And I think it's important to have open discourse and be open to criticism. But there's also, and I think other sessions have brought this out, there's also the risk of specialty bias. So you do what you know, there's the imperative to treat or to test, but also the fee-for-service conflict of interest. At least the Canadian Medical Association journal, where we publish a lot of our guidelines, have compared guidelines produced by specialties and by kind of non-specialty organizations. And as you would expect, the specialty organizations tend to promote increased use of diagnostic testing, which can lead to overdiagnosis and harms. So it's important to get the balance. I always say that it's important to be aware of the process, not necessarily be wed to a guideline, because guidelines change as evidence changes. We're reassured by the fact that independent review ranked our guideline, especially the recommendations in terms of are they useful or reasonable, were highly ranked. And I think that's because we've incorporated the conditional aspect with an emphasis on shared decision making. So it's a complex area, and I don't have the answer. I'm kind of interested in the discussion here. I think we've heard that, or I've heard from the literature that women want to be informed of breast cancer screening, but we're not rational decision makers. And we're communicating a complex and nuanced piece of information, including difficult to understand complex concepts like overdiagnosis, probability, and uncertainty, against a message of breast cancer is bad, it can kill you, get screened, it'll save your life. So we have an uphill battle there. There's also, I think as I mentioned before, the organization of screening programs which might not allow shared decision making and discussion. There's the external influences like what we see in social media, medicals groups, as well as what your friends and colleagues are doing. And there's a lot of confusion, and I think the pandemic underscored that as well. the general population doesn't understand uncertainty, and they mistrust experts when they see different points of view or a change in the evidence or recommendations over time. I'm encouraged by this conference and what I've heard, and we're hoping to continue to empower women, particularly within the breast cancer arena, so they can make informed decisions that are appropriate for them, that are not overwhelmed by or derailed or subverted by media messages. So I'll end it there. Thanks very much.
Thank you very much. I just wanted to add to that, just a little addendum, that group that of radiologists has actually been actively campaigning to have the task force disbanded. And they have also actively renewed their attacks on the Canadian National Breast Screening Study, and there is currently underway an investigation once again at the University of Toronto to look at that study because the accusations are that it was a fraudulent study. They've been fighting those accusations for 40 years. Okay, I would like to invite the panelists to come to the table, and we're going to be joined by my co-moderator, Dr. Guylaine Thériault, who is a primary care physician and also a member of the Canadian Task Force on Preventive Healthcare. And she will be able to help with any questions that Dr. Boer may not understand, so we may hear a little bit of French spoken. Okay. And Dr. Gallagher, I hope you'll be able to answer some questions too.
Renee, maybe just to talk to the points you brought up before is, cherry-picking studies is something that is not obviously in the best interest of evidence-based medicine, and some of those groups who have, or disagree with the guidelines want to insert kind of cherry-picked observational data and remove RCT data. Although some of that doesn't make a lot of sense. Removing the RCT data would mean there's even less and lower quality evidence on the benefits of screening.
Hello. Just a question for all of you, I think. And Dr. Clarenbach, in your slides, you mentioned some of the factors that women use to make their decisions, and one of them is what their circle of people around them does. It's a question for all of you because I wonder, is there a way that we, preventing overdiagnosis, our tribe, can use that tribalism to encourage not only breast cancer screening, but in other areas, people to make different decisions? I wonder if you see any opportunities for that or what that might look like.
Yeah, and I'm at a bit of a disadvantage because our KT team is probably in a much better position to address that question than I am. I think it's just a frame shift in terms of understanding that decision-making is complex and nuanced and uncertain, and that the message might be that you may or may not consider getting screened for breast cancer. It's an individual decision, and kind of highlighting that message might allow people to make the informed decisions and to come up with that. How to actually change that from a media perspective? I'd love to hear suggestions. As I said before, it's easier to say, get screened, it'll save your life, versus, well, you might want to think about uncertainty and probability and potential harms and benefits. That's the soundbite for that one is much more complex.
I don't know if I'll try to say something. I think also that what I said in my talk, we need to move away from attendance as a quality indicator. I think that's very important. And also I think we need to discuss, because it seems like women do listen more to other women. So I think we need to get the stories out where women actually feel that they have an overdiagnosed tumor and talk about how that experience was for them. And I think that, unfortunately, that seems to matter for people. So we can not only base our information on the thinking that they will, as long as you inform them well, they will make an informed decision. And questioning what is an informed decision. So we need to work a little bit more on that, I think.
Yeah, hi, Mette. I want to pose you a question. When I discovered the problem of this web page of our Inca, I was so shocked into stopping all my activity. So then I discovered that our national Inca has an international scientific committee. I wrote to each member of this committee, and I had no response but yours, and I thank you for this. So my question is, what is the real cloud or power for such an international scientific committee inside the Inca to not counterattack, it is too a strong word, but perhaps to break, pour freiner?
Influence, maybe?
Yes, perhaps to influence all the stuff that the Inca does not come to other stupido ideas.
I understand what you're saying. So yes, I am on the scientific board for the Inca, and we actually talked about this, and we all agreed that this was the homepage and what was written on it should that they should promote it in a more informed sense, and weighing the benefits and harms. And I'm very surprised to see that the homepage hasn't changed yet.
No.
So I will at least make an effort to put this on the agenda for the next board meeting as well.
I thank you very much.
Hi, I'm a family physician from Edmonton, and I found this talk very enlightening because it very much goes with my view. And I just wanted to share what happens when I tell my patients. I basically have the 1,000-person chart from the Canadian Task Force laminated in my clinic rooms. And most of my patients, I would say, are highly educated, university education. I just take it out when we have to talk about screening. I just take it out, show it to them, and I would say more than 50% when you show it to them say, this is ridiculous, we don't want the screening. So very different from your statistics. I'm not sure why, and the remainder either say we want the screening because of friends that have had cancer or family experiences, or they're just very, very concerned about their health, and that's why they want it. So maybe I should do just to publish a study on my patients because it's quite different from what you've mentioned.
I could just say that it's the same experience that I have in my family practice. It's about 50-50.
When we
Sorry, I'd like Dr. Theriault to expand on that a little bit about how she actually deals with her patients.
Well, I guess I do something very similar to what you just expressed, but I really, and others in the crowd do the same thing and take the steps of shared decision making. So really make obvious that there is a decision to make, and that's surprising to women sometimes. And then I use the tool like you do, and I try to elicit the values and preference of patient and acknowledge their concerns. But I have the similar experience as yours. It's about 50-50.
So I guess I'm about 300 kilometres south of you, but the major difference is that I do not own breasts, and so I find it much more difficult to have this conversation with patients. So I'm not sure if mine's as good as 50-50. I was going to ask Scott. I used the same 1,000 women diagrams. With the current type of imaging that's used, is it underestimating the harms? Because I know that they're using more and more sensitive machines, and so finding more and more things. And so is there actually more harm than what we're seeing in that? And if I could add another thing, I don't know whether anyone in the room can comment, but when I trained in the UK, I know that the radiologists had to do quite a lot of quality control, like if you were looking at images, they had to be looked at by millions of people to check that they were actually being, whereas I think here it's like, just happened to be whichever radiologist you get that looks at your pictures, and then that's who reports. And because the report is very variable depending on which of the 4 companies in Calgary you send people to, or where they decide to book. So I just wonder if you had any comments on that.
Yeah, and this is a bit of a separate question, but the question is, do we have it right on those 1,000-person diagrams? So that's reflecting mammography. The task force doesn't recommend any other imaging modalities because they haven't been studied in randomized controlled trials. They know the more sensitive you test you have, the more likely you are to have false positives, potentially more overdiagnosis, and it's unclear if that leads to a benefit. The other element is that there haven't been any RCTs done recently, so this reflects a previous era. There's been tremendous advancements in the treatment of breast cancer. So it's now I'm kind of opening up in terms of the uncertainty of the evidence. It's unclear if the same degree of benefit truly exists. There is a UK randomized control trial, the AJAX trial, which is ongoing and should be published in the next few years, which hopefully will shed some light on that.
Carsten Jorgensen from the Nordic Cochrane Center. I just wanted to mention a factor that perhaps hasn't been talked about here that limits informed consent. So I'm currently in a working group with the National Danish Health Authority where we reevaluate the Danish breast cancer screening program. And we've been discussing informed consent. And the attitude from the health authority is that once you decide to introduce a screening program, you go to war. And that's a quote, that you go to war. And as we all know, the first casualty of any war is the truth. So they are willing to provide information about harms, but not in a way that would lead women to draw the conclusion that more women are harmed by the intervention than are helped. They also hold on to the strategy of inviting women, giving them a specific date and time for an appointment. So they send an invitation letter, but their date and time of participation is already decided. And that is a very, very effective way to short-circuit any kind of informed consent, because it very clearly and unequivocally tells women, this is something you have to do. It's not really an option anymore. You have to actually actively opt out. So we're up against authorities that are actively working against informed choice.
So, Karsten, I think it's the same all over Europe, at least, where you have the programs. I don't know how to convince the bureaucrats and the politicians, but we cannot stop informing. We cannot stop doing the studies and trying to understand what is the benefits and the harms. And I think the harms might be easier to study in an observational setting than the actual benefits. So we just have to continue fighting, and we have to be aware that in order to publish, we need to have reviewers that acknowledge overdiagnosis, for example, which is for some journals also a problem. So we need to establish a loop, so where the information flows and we are aware on all levels. I don't know if that makes sense, but I think that's important that we think in the broad perspective.
Yeah, and I think if you wouldn't be there, maybe it would be even worse. Next question.
So there are clearly women who benefit from screening mammography, and I don't think any of us would deny that. So I'm wondering if the panelists could comment on whether some of these efforts we've been talking about have the risk of creating greater disparities for breast cancer screening in women who are at higher risk, such that we might be putting the underserved patients at greater risk for the harm of underdiagnosis.
I'll have a brief comment on that. I mean, I think that's a common theme, is that the people who have access to care probably get more care than they need and are overdiagnosed and overtreated, and leaves a dramatic proportion who are undertreated and maybe don't get the necessary care that they, including preventive strategies. But you bring up an excellent question, and I was encouraged by the talk yesterday where there's discussion of perhaps having a more nuanced approach to risk stratification. Mammography is just one tool that informs the probability of, is there cancer that is serious and will lead to serious clinical events in a person's life. But there's also other elements like family history, more genetic information. So I don't have the answer for that, but I'm hopeful that through some of the research that's been presented here that perhaps we might be able to identify those people who are at higher risk and have a more, again, I don't know how well this will be received, but a more nuanced approach to screening where the people who really need it, we make a big push to get them screened and to address some of the equity issues that you brought up.
So I also have a comment on that, because I think pushing or nudging everyone to do something doesn't necessarily being a push to the people or to people that are not so or underserved, because we have what we've seen in Norway when it comes to participation in screening is that we see that there is the people who are more affluent that actually attend screening, and by recommending it to everybody, it doesn't seem like that is really leveling out the inequity in health. So I'm not sure if your question is the right question. So the question would ought to be, are there some women who really, really will benefit from screening? We need to know that, because right now, as far as I know, we don't have really good data to inform ourselves on what is a big risk factor. Because what we're studying is, we're doing observational studies, and we're doing it in setting where you have most women accept screening and go to screening. So it's very hard to study then the harms because of overdiagnosis, because you already have established a screening program. So I wish that we could set up screening interventions or programs which could be more dynamic, in the sense that we can randomize people to less screening, and some after that maybe to more screening. So we need to start all over again, I think, with randomization and getting good evidence for mammography screening and those who really would benefit from it.
We are just about out of time. We actually are out of time, but Dr. Boer, if you have an answer to the question, it'll give you a brief few seconds to to participate in that question, and then we will close off the questions.
Yes, it's a good question, the risk assessment. I agree. And I think there should be launched some studies on this topic. But unfortunately, the study has been launched in Europe. It's called MyPEBS. And there are some issues. The problem is that there is no control arm without screening, so that a woman will have one choice, only one choice: screening or screening, standard screening or risk-based screening. There is no envision of a third possibility, not screening. And the other issue, and it's not the least, is that these studies are on a model of a non-inferiority study. And it is very confusing and puzzling, because the threshold chosen is very generous. In MyPEBS, it is 25%. So it means if you find in risk-based screening until 25% more advanced cancers, you can state, okay, it is equal than the standard screening. So replace the study protocol with your boss, and replace the efficiency of screening with your salary. Imagine now your boss is coming to you and say, so we will review your salary upwards or downwards. If it is downwards, it could be decreased in a range between 1% and 20%. Would you find this équitable, fair? Would you find this insignificantly? So this study, the design of this study is misleading and is cheating the woman. So I am sad to discover that we have impose this screening to the woman. And now we try to find a way out. And this way out is passing by a study that is bad constructed. The design is not good, it's not understandable. And the leaflet given to the woman in this MyPaps study is very deceitful and misleading. Overdiagnosis is underrated, and overtreatment is not mentioned. So I have the impression it is a repetition of the faults, all with the same faults. The real study could be useful. Would be a study about the natural history of cancer. Why some cancers are evolving so quickly and killing women, and why some cancers are not evolving or regressive. That could be useful. But I guess the MyPaps study is useless for women, and I am a little bit shocked that 12 million euros will be spent on this study, which will not give the response, is screening useful or not?
Dr. Boer, thank you very much. And thank you very much, Dr. Gallagher, for coming out of your sick bay to talk to us. Thank you, Dr. Clarenbach, and thank you, Dr. Theriault.